Hey guys, this talk is a direct continuation of my Achieving Excellence talk. We know that in order to be good at anything, number one, you have to have a get or done attitude. You go cheap, go now. You do something and use your PDSA cycle to get better. You focus on outcomes because outcomes are the only things that really matter. You become your subject expert using a smart plan and mastery learning. You be super critical of yourself all the time. Find your niche, find your team, and you will be the best at whatever you choose to do. Here we will use the development of PRMC tracheostomy technique as an example of not only telling you what our experience is and how we do tracheostomy here, but also how we use this PDSA cycle to get where we are today as far as airway management is concerned. And also by starting with the more difficult surgical airway and the reason how and why we do that surgical airway the way we do, we then can confidently track back and talk about actual day-to-day airway management as we expect you to do in the hospital. My name is Sangwan, and I am your Program Director for Pulmonary Critical Care Fellowship, APD for Critical Care Fellowship, Director of Interventional Pulmonology, Director of Center of Medical Education and Simulation, and I have been a certified ECMO specialist for some time now at Tidal Health. I have some inventions and patents, but none of them are causing any financial conflict of interest. I am the sole inventor of the easy tracheostomy tube that later got modified into the GemView LMA by my team. I have a Shikani standalone modification for intubation, a easy intubation LMA design. This single tube pleural pressure lavage was a technique that I introduced. Also the PRMC tracheostomy technique, co-invented with Dr. Chasse. I did write up a advanced pleural disease management algorithm. I worked on the design of a stationary ultrasound probe holder, and currently having signed a NDA, I cannot tell you which company, but I'm a consultant for a robotic bronchoscope design, which will be the next generation of robotic bronchoscopes. I have been an invited reviewer for a lot of journals, including Critical Care Medicine, Respiratory Care, Anesthesiology, and Journal of Cardiothoracic Surgery, and also Journal of Pediatric Intensive Care. And the reason I am an invited reviewer is because of my expertise in airway devices, tracheostomy, pleural procedures, and of course, interventional pulmonology. What makes me an expert at airway is because in my life until now, I have done about 5,000 airway management cases, out of which there are 3,000 intubations plus. I have done about 350 plus tracheostomies, and I have definitely done 10 emergent surgical airways in my life. A ER doctor, for example, in their career, on an average, depending on what ER they are in, would do about 8,000 intubations, out of which 200 intubations would be difficult, and a very small percentage would actually be a surgical emergent airway. Busy anesthetist in a busy hospital after a 30-year successful and active career would do about 10,000 intubations, out of which around 1,000 would be considered difficult. But on an average, if you look at carriers, 90% of anesthetists will never do a surgical airway in their whole career, and the other ones will do 5 on average. They do have the ability to reverse and stop the procedure and wake the patient up, which is what differentiates them from critical care or emergency care physicians. When I was an intern, a few months into internship, there was a code where I was doing a femoral central line, and nobody was being able to get the airway on the patient. So I took the central line kit and performed a retrograde intubation. that many critical care and emergency people have maybe not even heard of today. And because of that, I started getting called at night in cases of difficult airways, and I ended up doing about 3 surgical airways in my intern year in 2005. Since then, my numbers of emergent tracheostomies and emergent cricothyrotomies are not insignificant. And by the time I finish my career, I should be able to have at least 6,000 plus intubations, which is less than but is comparable to what an anesthetist would do in their whole career. So, one of the problems I always face is that everybody is an airway expert, even those who are not. And this is true for any procedure. Medical students can write a meta analysis. People who have not actually done enough procedures can do a retrospective study on it and suddenly become experts. Now, this might be okay with any other procedure, but with airway management, when you go into a patient room and there is a toilet in the room, I have seen meta-analysis and randomized controlled trials, all of them on this subject, go jump into that toilet and pull the flush. And now you are left with 30 seconds to 3 minutes to save the patient's life. So in this particular case, I would not take my experience as being equal to somebody who has read a lot of studies on the subject. And that is very important, because if I can't transmit what I have learned about this procedure of critical airway management, then the fall from peak of Mount Know-it-all to the valley of despair will be very steep and will hurt a lot, especially when you lose a patient because of overconfidence. So when I hear Dr. Sangwan in TikTok, I saw this video where somebody was doing something different. I actually hear it in one ear and then let it go on the other. But I should not be doing that, because I should be stopping this dangerous behavior in its tracks. When you tell me that in your fellowship or in your residency, somebody taught you how to do something differently, I can almost assure you that most likely that person has either done less critical airway management than me, because the statistics make it highly improbable that somebody has 2 or 3 times the experience that I have. They might have more than I do, but it will not be in multiples. So that's very important for me to tell you this, because at this point, my humbleness will harm when you are taking my advice that do not give paralytics when intubating critical airway in the ICU. When you use that as an equivalent of somebody else giving you an advice to do the opposite. So bear in mind that my experience in this matter is not insubstantial. I've given this talk multiple times in multiple institutions, but it is slightly modified from the presentation in 2016. So, what is not controversial? What is not controversial that a percutaneous dilatation tracheostomy is the first choice of how to do elective tracheostomies in critically ill adults, and I would say even emergent. Mortality is very low. Complication rates are lower than surgical airways. The infection rate and bleeding rate are lower than surgical airways, and it is cheaper and faster than getting a surgical airway done because of the fact that the patient has to go to OR. No doubt. And we also know that the single curve dilator technique is the technique of choice because it has been studied, RCTs and meta-analysis and systematic reviews, and it seems that compared to multiple step dilatation or compared to the Griggs technique or the translaryngeal tracheostomy technique, it simply has the least serious complications. and is also the fastest. In developed countries, it is performed usually by two operators using continuous bronchoscopy guidance, and when I became a fellow, that's how I was taught in the first month or so of my fellowship. So, what is wrong with PDT? The use of continuous bronchoscopy. You see, what is happening in PDT, okay, is very simple. A patient actually has a functional airway. They have a ET tube. And what we are doing with the tube is, number one, we are putting a bronchoscope inside the tube, and then we are taking that perfect airway and pulling it out, and we are pulling it out until the distal part of the airway, the distal end of the airway, lies above the or at the level of the first tracheal ring. And then at this precarious position, we take our time to actually do the PDT procedure, which is you put in a needle over catheter, you get some bubbles, you push the catheter inside, followed by a guide wire, followed by a punch dilator, followed by a curve dilator, and after that you put the tracheostomy tube onto a introducer, and it goes inside, and then after you have made sure that the tracheostomy tube is in place, you are going to remove the ET tube, and that's your normal procedure. In order to not have the hypercarbia and the hypoxemia and the increased peak airway pressures and the air trapping and other things that come along with the traditional way of doing this, people have tried other solutions. They have tried to use a pediatric bronchoscope, or the other thing is that, hey, don't do a tracheostomy unless you are a 100% critical airway expert, so that if you accidentally dislodge the ET tube, you can get it back again. It can be very difficult if you have started to bleed at that time. Know your anatomy, and of course you can use simple solutions like minimize bronchoscopy time by using direct laryngoscope to assist in ETT positioning instead of the bronchoscope, and then dissect to the anterior tracheal wall and feel the anterior tracheal rings, and then use your bronchoscope for the last 1 minute or two of the actual tracheostomy procedure, including introduction of the wire and dilatation. And that is, it seems very smart to use a pediatric tube, because obviously, anybody who has a tube of less than 7.5 or equal to 7.5, if I put a normal bronchoscope in it, it actually acts like a tube of 5 millimeter inner diameter, and that is so difficult to ventilate through. If I use a pediatric scope in the same patient with a 7.5 ET tube, my ET tube acts as a tube of 6.5 millimeter diameter, and that is better. I don't know how clinically significant it is, but it is better. The problem with the pediatric scope is that there are secretions in the airway which is very difficult to clean, and also pediatric scope might not always be available, and if you lose the airway, you cannot use the pediatric scope for reintubation. Recently, we were doing a tracheostomy in the same center, and my fellow accidentally opened a slim bronchoscope for the procedure, and we had a lot of difficulty, which illustrates the point. Because you see, when I was being taught how to do a tracheostomy, there were two people managing the airway. There would be somebody holding the tube and another person holding the bronchoscope, and it was almost impossible to have them move together. It would take half an hour for them to coordinate and come up to a point where the ET tube and the bronchoscope are not moving relative to each other. And every time the dilatation or the palpation of the trachea happens, the tube would move and it would be the same thing all over again. So one of the first thing I started to do was that I would teach my co-fellows to hold the ETT, the scope, and your hand and make them one, so that one person manages the airway. And once you have bronchoscope at the end of the tube, you are always going to maintain that relative position, and you are going to manage the bronchoscopy and the airway at the same time. And that worked out pretty good. With the pediatric scope, you'll always have a leak, which is a problem, and then secretions are a problem, and reintubation is almost impossible because it simply does not have the strength to guide act as a stylet. So once you are at the end of your ET tube, you make it one, and then you keep pulling back until one day your tracheal rings finish. And once the tracheal rings finish, you come up to a tracheal ring which is larger and fatter and wider than any other you have seen, and that is your cricoid cartilage, the only complete cartilage. Looks like a wedding band. And then you start having a smooth triangle, at which time, if you decide to continue pulling back, you will start seeing the vocal cords, and if you keep pulling back from that, you have extubated the patient. Once you have reached the cricoid cartilage, you start counting the rings from the top, and then you park yourself just at the level of the first ring so that you can use the first, second, or third tracheal ring space to actually do the procedure. And at the minimum, I always want a part of the ET tube, the distal end of the ET tube, to be visible so that we always know that we are still in the airway. At this time, very gently, somebody would be inflating the balloon, and only inflate enough so that there is a manageable leak in the ventilator. Because at this point, if you inflate the ET tube balloon too much, you'll either be pushed down or most likely you'll be pushed out of the airway, and that is a very bad situation to be in. If you are a good fellow who can follow directions, you will know that I would like it even more if you put your bronchoscope into the ET tube such that you see a part of the eye of Murphy, so that while you are looking at the distal end of the ET tube with your bronchoscope, and also doing a thumb down so that you can see the anterior wall with all its tracheal cartilages and the spaces in between the tracheal cartilage. You're also keeping an eye on the eye of Murphy and making sure that you see maybe the cricoid cartilage peeking out from here. Because if I accidentally push you back before you extubate, you will actually see the vocal cords peek out of here. And when you do that, you know that immediate reaction needs to be that you immediately move forward and re-secure the airway before I extubate you. While I was struggling with the problems with bronchoscopic guided percutaneous dilatational tracheostomy, Dr. Chasse, who I had not met until now, was working on his own solutions. What was his solution? Number one, bronchoscopy guidance is controversial. In the academic centers and many places, they will make it feel like it is mandatory. It is not. In fact, when these studies were coming out, less than 50% of the studies used bronchoscopy guidance. Okay, and everything was retrospective, not prospective, and there were studies using intermittent or no bronchoscopy, and they showed really low rates of complication. 3,000 patients in the Dennis study, complication rate without bronchoscopy was 0.38. Airway loss was only 1 in 1,500. In the Simon study, all it added to say was that, although death and complications are very rare and mortality will be like 0.17%, but of the deaths that did happen, Simon thought that 30% of those could have been prevented if there was bronchoscopic guidance. So there is a good and bad points of bronchoscopy. And then there are other people that, hey, I can confirm needle placement, for example, using end-tidal carbon dioxide monitoring. So, you put the needle in, you get bubbles, you push in the catheter over needle, and then you attach it to end-tidal carbon dioxide, and you know that you are in the tracheostomy tube. So, people at that time were using direct laryngoscopy, and in direct laryngoscopy what happens is that you simply deflate the balloon and pull the tube out until the balloon is almost half out of the vocal cord, and then while doing direct laryngoscopy you are going to inflate the balloon and make sure that it is not pushing the ET tube out and your leak is minimal. And once you do that, you actually do a blind anatomically and palpation guided PDT, and then once you are done with the guide wire, you take the bronchoscope down and confirm that the guide wire is in a place that you like. Then you take the bronchoscope back out again and complete your percutaneous dilatational tracheostomy, followed by another bronchoscopy both from inside the tracheostomy tube as also the ET tube. The only difference between this technique and what Dr. Chasse was doing is that instead of a direct laryngoscopy, he would put in the bronchoscope, take it to the end of the ET tube, bring the ET tube back, and then ask a respiratory therapist to inflate the balloon and then hold that ET tube. He would take out the bronchoscope and then he would follow the procedure exactly to what we are telling you in these images. Downside of the DL technique was inability to get DL view to do a precise withdrawal sometimes, but then once you get a glide scope, that is not a problem anymore. But accidental extubation can still happen because you are still hanging at the vocal cord level, and posterior wall puncture is a possibility because you are not actually seeing the needle go in on the bronchoscope. Although when you use the bronchoscope, in my humble opinion, I have just seen that the bronchoscope helps you see that you are in the posterior wall. A better thing would be to have control over your hand so that you stop at about 1.3 centimeters and never exceed more than a centimeter inside the trachea itself before you push the catheter in, and then you don't have a needle in anymore. And Kornblith did about 1,000 patients with intermittent bronchoscopy, so it's not something that has not been done before, but they did have a 20% incidence of posterior tracheal wall perforation when Dr. Trottier studied that. So it's still a problem. There are still problems with the procedure, so there are some complicated solutions, and the complicated solutions for various different problems. If you're having a ventilation issue, you exchange the ET2 to a bigger size. ETT to a bigger size, so you exchange it. If that is not possible, you actually exchange the ETT to a smaller pediatric tube and then place a bronchoscope alongside. That has also been done. You could exchange the ETT for an LMA or another supraglottic airway. That has been done. And you can use specialized airway devices, or just say, I'm not going to do bronchoscopy at all. And all of these are complicated because you have a perfectly working ET tube, and then you are taking it out, and then you are exchanging it, and there are so many complications that can happen during that time. An example of a nonsense proposed modification is this, where in order to facilitate reintubation in case of accidental extubation, you put in a exchange catheter in first, and then you do your bronchoscopy guided PDT with the exchange catheter placed near the carina, so that in case you extubate, you simply reintubate using that as a conduit. Imagine the ventilation problems here. I am trying to get rid of the bronchoscope inside the ET tube, and you are putting a bronchoscope and an airway exchange catheter alongside. An example of a specialized airway would be this odd looking ET tube where there is a posterior extension of the distal part. So now what happens is that when you find your space, you can park there, and it will prevent posterior wall puncture. It will facilitate better visualization of the anterior tracheal wall, but again it requires an airway exchange. And the bronchoscope remains inside the ventilating lumen. This is how they do this modification, where they are using a pediatric ET tube in an adult and then placing the bronchoscope alongside so that the viewing and the ventilation are separate. But you can imagine the leak because of the fact that a pediatric ETT balloon will never occlude the whole trachea, and therefore although it solves one problem of visualization and ventilation, it creates others, and therefore is not something that I necessarily would suggest that you do. Using the LMA has up to 33% failure rate, where you have to, if you're not quick enough, you have to take out the LMA and then re-intubate the patient. And although it gives a very superior view of the anatomy, it does allow you to count the tracheal rings like no other modality though. So I do like it, and I have used it once or twice, but it's not my favorite for various reasons. So I came up with a possible solution. I'm like, hey, why don't we have a double lumen tube? And if we have a double lumen tube, then we can use one tube to ventilate with a balloon which is asymmetric, so that when you inflate the balloon, it actually pushes the longer ventilator tube backwards so that you have more space in the front, and then it is sized so that the viewing tube ends up exactly at the vocal cord. In fact, you can help that because I made a vocal cord marker. When you have the vocal cord marker at the vocal cords, the tube extends about 10 centimeters beyond that, which, knowing that most adults have a tracheal length of maybe around 14 centimeters, it would give you enough space to do the procedure without causing single lung ventilation to happen because you are beyond the carina. And if I was able to do that, I would put a pediatric bronchoscope into the viewing tube, and because of the size of the viewing tube, it would be a tight fit, and because of that, I would be able to simply hang the bronchoscope on a holder or a ivy pole, or just put it along the bedside, and it will never move because it is stuck inside the viewing tube. And therefore, once the tracheostomy is going on, I cannot lose the airway because my distal end of the tube is right at the level of the carina, and I am not losing any ventilation or airway at all. The beauty was that if I could not complete the tracheostomy, I would simply leave this tube in. It's a ET tube and it's made up of the same material with a low, high volume, low pressure balloon at the very end of it. So I would not have to re-exchange. And I thought that it would solve a lot of issues. So here we go. The distal end of the tube would be at the level of the carina. The distal end of the viewing tube would be at the level of the vocal cords, and you would use this space, anterior space, to actually perform the tracheostomy with a bronchoscopic guidance. And knowing that the trachea is expansile, you can expand it, it's flexible, and the ET tube is compressible, you should have enough space, I postulated, to actually do the procedure. And once I'm done with everything, and at this time I'm ready to put the tracheostomy tube in, is the time that I withdraw my ET tube and put the tracheostomy tube in so that we don't get stuck in there. Now, has this been done before? It seems that Velma Hos did actually presented it in 2000. he used to do the same thing but without bronchoscopic guidance. So he would push in the ET tube until it reaches the carina, and you can use X-ray, you can use 26 centimeter depth, you can use the tidal volumes you are getting on the ventilator. There are so many things you can do to figure out, including a stethoscope, to figure out that you are at the carina or beyond it. And then you pull back the tube until you are at the carina and inflate it there. And then he would do a palpation, semi-surgical tracheostomy until he felt the tracheal rings, and after that he would identify a space, he would put in the guide wire, he would dilate, and once everything has been done, he would put his finger inside the hole and use that to pull the ET tube back above the area of insertion so that he can complete the tracheostomy. So it has been done. Well, I presented it to my program director. He asked me to patent it. One of my friends, Basel Altaki, actually said, I think an LMA base would be better. I didn't listen to him then, but he ultimately proved to be right. So this is my tribute to Basel Altaki. I went to the sim center. I did a tracheostomy with a model that I had made, and it worked perfectly fine. After which I did a study on a cadaver after making my own model, and not only was I able to do the tracheostomy exactly as intended, I could do it single-handedly because of the fact that I did not need to hold the bronchoscope in place anymore. Because of the fact that while pulling during the final step, when I'm pulling the ET tube back, I didn't want to have to pull the whole apparatus back. What I did was I made a final tube-in-tube design so that the ET tube could actually slide in and out of the viewing tube, which was actually attached to the balloon that would give you ventilation even when the distal balloon is deflated, because of the fact that you are actually using it like you would a supraglottic airway. So I made those models myself. I still have them, and they were a big hit in Tulane. Downside to this was that you needed a pediatric scope, which means that clearance of mucus would be a problem, and you needed a tube exchange. But it solved a lot of other issues with percutaneous dilatational bronchoscopic guided tracheostomy. This is the DLET. It is the same tube. It is being sold in Europe. I guess the Italians like it. They use it. And it is exactly the tube that I am talking about. And there was a paper by Dr. Vargas in Chasse. You can read that. The tube works exactly. But I did not use the tube. I did not use that tube. The reason I did not use that tube is simply because if I have to do a tube exchange and I have to do a re-intubation essentially at the beginning of my procedure, then how does that solve issues? I could just use the regular technique, and if I extubate accidentally, I just re-intubate. Now, the argument in favor of this technique is that you do a controlled re-intubation right at the beginning instead of an emergent re-intubation when you lose the airway. That's one thing. And the second thing in favor is, hey, if you can't re-intubate, you should not be doing percutaneous dilatation or tracheostomy. But because of this, I said, before I start inventing more and more things, let me figure out what exactly do I want. And essentially what I wrote was that modifications aimed at reducing accidental extubation will worsen ventilation. And modifications aimed at improving ventilation will either require an airway exchange or lack the ability to give continuous bronchoscopic visualization or any continuous visualization of the actual procedure. And therefore, an ideal technique should have uninterrupted ventilation, no possibility of accidental extubation, continuous visualization of some kind, no severe bleeding, no misplacement, no posterior wall damage, no damage to the scope or the ET tube, and B, cost effective and user friendly, and therefore I said the ECT is not the answer. But knowing that I have a double tube in tube design, and when I separate those two, I am actually using a ventilation tube over a regular ETT. Then why do I need to do a tube exchange? Because I could simply use the viewing tube and slide it over the patient's existing ET tube, and boom, I have got easy tracheostomy, I have got the visualization, I have got the ventilation without a need for airway exchange. And that went to Tulane Biomedical, and they decided that instead of doing a supraglottic combi tube airway style, they are going to do a LMA airway style because of the fact that a round balloon can rotate, but a LMA, once placed good, does not do that rotation. There is something called a air tube, and the air tube was invented by Dr. Areski in 2007 and looks a lot like my tube, where you slide it over the ET tube and then use a bronchoscope to withdraw the patient's current ET tube back to position. But if you accidentally extubate, you still have a supraglottic combi tube like airway up top with a balloon preventing air leak. The problem though is that you will still have esophageal air and stomach air because there is nothing stopping air from entering the esophagus. And the second thing is the bronchoscope is still inside the ventilating lumen. So this is the EasyView LMA, and this LMA is designed to slide over the patient's existing ET tube, and once it does that, the tube itself that it has in the front becomes your viewing tube, where you put a pediatric scope, and then you can do a single operator tracheostomy, because when you are withdrawing the tube, you are still always having a LMA in place, so you never lose ventilation. And that is the EasyV technique. Exactly the same as Easy Tube, except that you never actually have to take the patient's ET tube out. You just have to place a LMA over that tube. Now when I looked at that, I'm like, okay, but if a extubation happened, will this LMA be able to reintubate? And in 1997, somebody had actually invented the intubating LMA for blind endotracheal intubation using a LMA while ventilating. And then there was something called a C-track LMA, which was a LMA with an inbuilt fiber optic visualization inside it. But it was reusable, it was not disposable, it was very costly, but it was available. So I used my wife's kitchen utensil, a big spoon, to actually make this modification to the EasyView or GemView LMA, so that it can actually be used as a disposable, cheap, fiber optic intubating LMA instead, by giving it little bit more rigidity. And you could ventilate at the same time that you are visualizing, because it is a double lumen intubating fiber optic LMA. In order to help with the problem that the pediatric bronchoscope has a small channel, and secretion clearance and blood clearance is difficult, I used the same technique that I had used for my critical airway management standalone Shikani modification, where we have a jet of oxygen being delivered through the working channel of the pediatric scope, so that the secretions always stay away from the edge of the scope, and you will always have good visualization. In 2026, this LMA has been made. We have a disposable video laryngeal mask LMA, which would be perfect and game changing for so many reasons. And forget tracheostomy, I do want Chen, my academic fellow, to do this study. Okay? So here's the study. When you go to a code and there is no airway, immediately put this disposable LMA in. Now you have ventilation. You have one every 5 or 6 seconds ventilation. You don't have to bag mask. 2 people don't have to stand at the head doing 2-person bag mask ventilation. You can hook up to end-tidal CO2 so that chest compressions can be continuous. And during this time, you can try as many attempts at intubation without ever having to stop the compressions. And that study, whether successful or failure, will still be published and people will still learn from it. But I think that that is a big opportunity to do something which will put your name out there. Having said that, when I came in here, I learned from Dr. Chasse what he was doing, and I was like, wait, do I really need my invention? Because this is what I started doing. So instead of doing what Dr. Chasse was doing, which is start with putting the bronchoscope in, taking it to the distal end, and then bringing the ET tube back to where you want it to be, and then taking the bronchoscope out, I did the exact opposite. I would take the bronchoscope, I would put it in and use it to push the ET tube right to the carina. And then I would come out, I would use palpation and dissection to get the needle and the guide wire in where I want. And then I would do the bronchoscope again after changing my gloves, and I would pull the ET tube out proximally to where the guide wire is coming in. And if everything looks okay, I would take my my bronchoscope out, and I would complete my percutaneous tracheostomy blindly, after which I would go back in and check everything is okay, and I would then take the ET tube out after I have bronchoscoped both through the ET tube and also through the tracheostomy tube. At this time, people had started using pre-procedural ultrasound. We were always using pre-procedural ultrasound to make sure that there are no big blood vessels. We were already doing that. And then people started commenting that why can't we do a tracheostomy exactly like a central line with continuous or intermittent ultrasound guidance. And that Dr. Gobato had shown in 2014 that is something that will absolutely work. And visualization is visualization, and I don't understand what is the difference between ultrasound and bronchoscopy. So, Rajaji started doing this. He would take a direct laryngoscope and he would pull the ET tube back right to the vocal cords. He would then use an ultrasound guidance to put the guide wire in, just like you would do with a central line. And then he would go in with a bronchoscope, check the guide wire, then the bronchoscope comes out and he does the tracheostomy exactly like I would be doing it. The only difference between his technique and the technique that we had is that I combined all of it. So now what is happening is, and this is a video of the ET tube being withdrawn under ultrasound guidance to just at the level of the first tracheal ring. So now we have the Sangwan Chasse PRMC tracheostomy technique. I would use the ultrasound to make sure that it is safe to do tracheostomy. and then use the ultrasound to push in the ET tube until I see a change in ventilation telling me that I am in the right or left main, and then I would pull it back until I start getting the tidal volumes I'm giving. After that, with the ventilation still going on, I would use the ultrasound and the pullback technique and bubble technique to enter the space that I want to enter and also to put in the guide wire. During the pushing in of the guide wire, we would deflate the balloon momentarily. After that, I would take my bronchoscope, I would put it in, and I would start withdrawing back until I see the guide wire. Then I would complete my tracheostomy. Then finally, I would do the bronchoscopy again. And when we did this technique in 60 people, we actually found that there were no accidental extubations, no visible posterior wall puncture or laceration, and only in 1%, 1.6%, we could not complete the technique as we have described it. And we had to use, for example, continuous bronchoscopy. So this modified PDT is an improvement from any other technique that I have seen, because it's a combination of so many techniques. Which brings me to the point. You do not need a high IQ to be able to invent something or change something. You don't need that. What you do need, though, is what I call I4. Always identify deficiencies. If all knowledge goes away and humanity is only left with this slide, you'll be able to reinvent everything back. Identify deficiencies. Always be super critical of yourself and others when it comes to procedures. No matter what I'm doing, if I'm doing kayaking, sailing, flying, I'm always looking at what am I doing wrong, what can I do better. Once I identify what can I do better, I immediately intervene. I do something about it. I do something. And then I investigate what was the effect of my intervention. Because if there was a bad effect, at least I know what intervention does not work. And I keep going and I keep improving, and the cycle continues until I can't improve anymore. And that is then an invention.